80% of us will experience it at some point in our lives. Currently, about 4 million Australians are suffering lower back pain. And whatever form it takes, a sharp stab, a dull ache, or the jolt of nerve pain, it can be debilitating.
I felt as though someone had stabbed me in the back, just above the hip area, and it felt like a knife, and it doubled me over.
For 40% of people, the pain will become chronic.
It's always there. It just comes in waves in terms of how intense it is. When it's bad, it's really bad, and I can barely even lift anything, and I can barely even walk.
People with chronic back pain often suffer in silence, fearful of being misunderstood or reluctant to be a burden.
I hid the pain. It made me feel like somebody who just made a fuss.
But what if we could end the agony? Recent advances in science and medicine are transforming our understanding of chronic back pain, opening the door to new treatments.
We don't look at pain and just think that it's something that's entirely physical, that's entirely structural. A lot of it's to do with how impulses travel to the brain and how the brain interprets it.
The technology in the device is heroic. The initial results have been very, very exciting.
We are one of one research group who are taking on this really exciting new area of neuroplasticity to find techniques to reduce pain. The exciting bit is that we're onto something here.
Pain is awful. Most of us would do anything to avoid it, but it is essential for our survival. It serves just one purpose: to protect us.
Pain is a conscious experience, and it makes us do something to protect our body. Now we understand pain to be about protection, not about a measure of damage.
Pain is our inbuilt alarm system, a guard dog, alerting us to actual or potential damage. The process is called nociception.
Nociception refers to the danger detection system. We have danger detectors that are spread through all of the tissues of the body.
Pain's usually triggered when the brain receives messages from these danger receptors, the nociceptors, indicating they've detected something potentially harmful.
So if you bend over and you're picking up a heavy box and you feel sudden back pain, danger detectors have been triggered in your back and they send a message into your spinal cord. The message goes to the brain, danger, and then the brain evaluates all the other input and decides whether or not this organism, me, needs protecting. And there we would say nociception, or danger to the tissues, has triggered pain.
So while you feel pain in your body, it's your brain that's ultimately responsible for it.
We know 100% for sure that no brain, no pain. We know we need a brain to have pain.
Now, acute pain is relatively straightforward, but when pain becomes chronic, things get complicated. Why pain persists in some people but not others is a medical mystery.
The $100 million question: why some people develop chronic pain and why some people not develop chronic pain, although they have the same injury.
A pain going from acute to chronic is quite unpredictable. It's difficult to see how some patients will recover quickly and how some will go on along a chronic or persistent pain pathway.
It's a pathway Greg Paul has been travelling for years.
5 years ago, I was active. I was pretty fit. I used to be able to walk kilometres, walk for hours. Now I struggle to walk 100 metres without pain.
There was no major incident that triggered Greg's pain. It just slowly developed over time, becoming relentless.
The constant dull pain, it's like someone just grabbing your back and squeezing. And it's just getting worse. The burning down the leg. Both groins are just shot, they're just on fire the whole time.
In attempts to fix the problem, Greg endured 8 procedures in 6 years. But As is often the case with chronic back pain, they brought little relief. The pain kept on.
There was really nothing that worked. At no time did I walk out thinking I'm good. At no time did I actually feel I was out of pain.
It's exacted a heavy toll on Greg.
Well, 5 years ago, put me in a party, I'm happy. Now, family dinner night just with the kids and the grandkids, I just cannot cope with noise, can't cope with people around me. I just can't cope.
And a heavy toll on his family.
When I see it on him, and I can see that it's affecting him with his family, because they're missing out on so much. Sorry. This is just... you want to be strong for them, because you want their father to be there for them and experience just everyday life with them.
In the hope of getting relief, Greg and his wife Deb have come to see pain medicine specialist Professor Michael Cousins. He's heading up a clinical trial for a revolutionary new device for back pain. It's a next-generation spinal cord stimulator, engineered in Australia by Professor John Parker and his team. Danger messages travel as impulses. Electrodes inserted within the spinal canal send an electrical current into the spinal cord to block these signals, stopping the pain. While spinal cord stimulators have been around for decades, this one is fundamentally different.
Conventional implants are kind of blind to what's actually happening. The only thing that they can do is give out their signal. They can talk, but they can't listen.
But with this device, there's a two-way conversation.
So this is the first device where everything is based upon the feedback from the person. We're actually getting feedback from the person's own nervous system about how to continuously adjust the stimulus that's given. And in that way, we can optimise the level of pain relief. We're the first in the world to do that.
So by listening, the device can regulate the amount of stimulus to match the level of pain, giving a dose of pain relief tailored to the patient's needs at the time.
Greg.
Before Greg can be admitted to the trial, he has to pass a medical assessment. It's a nervous meeting, but one that could change Greg's life.
So, Greg, would you tell me exactly where are your pain areas and indicate which are the most important? There's the line.
Okay, yes.
No pain?
Yes.
Worst pain imaginable?
Yep.
And you've got to work out where you fit on that line?
At this point right now? Or?
Right now. Yeah.
Right now. Okay.
That looks pretty high to me.
As Professor Cousins runs through the remaining criteria, it becomes clear just how much pain Greg is in and how much he needs to be part of this trial. It's Greg's increased pain after his previous surgeries that's caught Professor Cousins' attention.
It's not that the surgery has failed, really. It's that it's been an unusual response in your nervous system. So from now on, we need to target the sensitisation of your central nervous system.
In sensitisation, the pain itself modifies how the central nervous system works. The greater the number of danger signals sent, the better the system gets at sending them. The danger response is amplified, and the bottom line is more pain with less provocation. And this is exactly what's happening in Greg's case, making him a good candidate for the trial.
You'll be the third person to have a trial.
The first two patients, how'd they go?
Pretty good.
Oh, that's good.
Once again, Greg is hopeful for the future.
I think it'll give my life back to me. Maybe it'll give me back to the family. See ya.
Can't reach.
It's the day of surgery, and Greg's on his way to theatre. Although under sedation, he'll be awake the whole time to give verbal feedback.
More to the left.
Professor Cousins uses a special needle to insert the leads into the space around the spinal cord.
The tip of the needle is in the epidural space now, and we need to thread it up as close to the midline as possible.
It's delicate work. Electrodes embedded in the wires must be in just the right place to activate the nerves and block the pain messages.
Now, Greg, you remember we talked about laying the stimulation over your pain area? We want you to tell us where you're feeling it and how much of your pain is being covered. Pretty soon now, we're just turning it up, you'll feel the buzzy feeling in your back or in your legs. Would you let us know as soon as you feel that?
Spinal cord stimulation works to not only block the pain signals, but to turn down Greg's sensitised nervous system.
Lower back.
That's good, Greg.
As well as a breakthrough for treating pain, the device records nerve impulses, which can be used to study the spinal cord.
We're learning about the spinal cord in chronic pain in a manner that's never been possible in humans.
Greg's out of the theatre, and it's a good result.
We finished up with two 12-electrode leads in a very good position, covering all of your pain area, as a matter of fact.
Thank you.
It'll be a few weeks before Greg feels the full effect of the implant. But this is a crucial first step towards a life with less pain. Pain is complex. Chronic back pain, while rarely a true representation of the damage, has the power to shape the very system that creates it, including your brain.
It's just the same as if you ride a bike a lot, you get better at riding a bike. Play the piano a lot, you get better at it. Send danger messages a lot, you get better at it. And that's an adaptation. And the same thing occurs in the brain.
Brain networks that produce pain, like those in your spine, become more efficient, needing fewer danger signals to evoke the agony. And pain's effect on the brain might not stop there.
I was at the gym and I was doing an exercise where you're meant to have a straight back, and I think that I must have been arching my back at a wrong angle because the next day I was just in a lot of pain.
Michael had an acute injury that he expected would heal. But instead, it became chronic.
It definitely affects my job. It also affects my sleep. I try not to let it affect what I do and when I go out, but I definitely do still feel the pain. So in that sense, it does affect my mood and my emotional state.
Michael stays active despite the pain and finds playing sport even brings temporary relief.
Yeah, look, I definitely use physical activity to kind of get my mind off things. When I'm feeling the pain, I want to go for a jog or I want to kick a ball around. But then as soon as I'm finished, my mind is back on the pain and it's there again.
And at just 22, he faces another battle.
People don't really link back pain with, someone in their early 20s. I kind of feel like they don't quite understand that back pain can happen to anyone, regardless of age. People tend to say, oh, you're young, you'll get over it. But for me, it's definitely a real issue.
Not understanding why his pain continues, or if it'll ever go away, plays on Michael's mind.
I sometimes do get anxious about the future. I wonder if the pain will ever disappear entirely. I thought it was mostly just coming from activities, but I sometimes do wonder if there's a bit more to it.
Could something happening in Michael's brain be the reason his pain won't fade away? This is the question neuroscientist Dr. Sylvia Gustin is trying to answer.
A lot of people come to me and ask me the same question. So they ask me, look, my injury has healed, but I still have ongoing pain. So what's going on in my body? Is there a pain center in the body, or particularly in the brain, which drives the pain? And this is actually where my work starts.
Sylvia's new study is investigating if the brains of people with chronic back pain are different to the brains of people who are pain-free.
We are interested in the brain, and we believe because of subtle brain changes, so anatomically, functionally, and biochemically, these people can't get rid of their pain.
Michael is taking part in the study, hoping to solve the mystery of his pain. The study's looking at two brain regions in particular, the prefrontal cortex and the thalamus. The prefrontal cortex is involved in emotional and cognitive processing. The thalamus acts like a gateway between the spine and higher areas in the brain. When you have an acute injury, the information gets forwarded to the spinal cord and then to the thalamus. This opens the border and messages get through. Usually after a few days, the border closes and the pain stops. But the scans have revealed something interesting about the brains of people with chronic pain.
What we found is that people with ongoing pain have structural, functional, and biochemical changes.
The volume of both the prefrontal cortex and the thalamus decreases, resulting in a drop of the neurotransmitter GABA. GABA is responsible for damping down signals and regulating the central nervous system. This loss of GABA in the thalamus means patients feel more pain.
This means that the border is always open and every somatosensory and pain signal is amplified, and this exacerbates the pain experience.
Falling GABA levels in the prefrontal cortex affect emotional control.
Emotions get amplified, and this might explain also why people with ongoing pain a lot of times have also emotional problems, anxiety and depression.
Having an understanding of what's going on in his brain has helped Michael better cope with his symptoms.
Talking to people who really know about pain, it's given me a sense of reassurance that pain doesn't necessarily have to last, and there are things you can do to prevent it. It definitely has increased my understanding of back pain and given me a bit of hope for the future, to be honest.
So chronic pain is associated with disrupted processing of signals from the body and reduced emotional control. Both play a key role in the persistent experience of pain. So if the brain changes with pain, it begs the question, can it change back? Can you use the brain's plasticity to dial down the pain?
1, 2.
Professor Lorimer Moseley investigates the role of the brain and the mind in chronic pain.
We're fundamentally adaptation machines. The exciting part is that if we can give the right demands to the system, we can adapt it back.
Often people with chronic back pain are unable to accurately identify where they are being touched or even discriminate between two different points.
Great. This is about your threshold. Mm-hmm. So that's probably slightly larger than we would expect in someone your age and fitness.
The patient loses precision in the map of their body held in their brain.
We know that the fact that we have to put those 2 points further apart on you than we do in most people tells us that that's a difficulty that your brain's having, and that does link to pain levels. What we want to try and understand is what are the reasons that the brain's making this happen.
So brain areas devoted to different body parts or functions start to overlap. The motor and sensory areas, in a way, become smudged, which results in the pain spreading.
The brain no longer produces this experience in a nice confined little area. It now is imprecise. Pain is spreading or pain is moving. The good news is that we can train that, and we can train precision. This is a photo of a back.
Yep.
And you can see 16 points there.
Mm-hmm.
All right, if you feel that, that's blunt.
Yep.
But that is sharp. Can you tell the difference between this?
Yep.
Okay. Tell me which one I deliver.
Sharp. Blunt. Sharp.
These tasks interrupt and correct the way signals from the back are processed by the brain. With repetition, the brain gets better at accurately processing the signals. The area of pain reduces and the person's symptoms decrease.
6 sharp. Nice.
It's a very simple technique, and we've got good evidence that this is helpful.
But according to Professor Moseley, understanding pain is the single most important thing you can do to start your road to recovery. And his Explain Pain program is designed to do just that.
We identify every single danger cue, and that can come from all sorts of places, different systems in the body, movement systems, your behaviours, also what you think. what you believe, what you feel. If you can stick at this, recovery is back on the cards, but it's slow. There's no quick fix.
The Explain Pain program and sensory and motor retraining are being tested in a large clinical trial, currently underway at Neuroscience Research Australia.
12. Good.
But in the meantime, care programs incorporating these insights are having positive results, even for those who have suffered for years.
Well, even as a child, I did have pain. I said to Mum and Dad, it hurts when I practice the piano. I still have that pain. And to try to describe, it's like trying to describe blue to a blind person who's been blind since birth.
Elizabeth Haslam has spent most of her life in pain. Pain that was unacknowledged.
I'd been told that there was nothing much wrong with me, and I was sent to a rheumatologist. He just almost shouted at me and told me to go away, get lots of exercise, eat a healthy diet, and stop moaning and groaning and not running around looking for the answers to my problems.
Discouraged, Elizabeth hid her pain for decades until she hit a crisis point and was eventually referred to neurosurgeon and spinal surgeon, Mr. Y.H. Yao. At Mr. Yao's clinic, a new understanding of pain is combined with the traditional approaches like surgery and medication. It's a multi-pronged approach to tackling back pain.
Understanding is key. The education side underpins our treatment because it's very important that they buy into the concept that pain is not purely structural, that there are many things that we can't explain and that pain is very complex.
In terms of last time we talked about...
For Elizabeth, her long journey to treatment meant her system was highly attuned to pain. She also had deterioration in her spine, which required surgery.
So Elizabeth did develop problems with her lumbar spine. She had pain radiating down her leg from nerve compression as part of general wear and tear. With collapse in her vertebrae, we had to put in some stabilization, to put in some metal to fuse the spine.
It has lessened my pain. Those operations have made an enormous difference to my life.
Tell me about your back and your leg at present.
The pain really responded to the surgery.
While her pain's reduced, it hasn't gone completely. So Mr. Yao prescribed a pain management program, incorporating both mind and body.
Part of the management of persistent pain or even acute pain is pain psychology. This is not just about reducing anxiety or identifying and treating depression, but it's about knowing what pain is, what the brain is perceiving, knowing that this is real, that is what they are actually feeling. But somehow the brain has the power to both dampen it right down, but also to wind it right up as well.
Elizabeth uses many cognitive strategies to wind down her pain.
I was taught diversion therapy, where you get your mind off the pain and divert your mind onto other things. And of course, the prayer and meditation is part of that. And the best thing I can do is go outside and look around my garden. I love my garden, so that's another diversion therapy. To keep your mind active, one of the ways of doing it is to take up something you've never done before. I love colour and design. And so I've bought a book and I'm about to pick up the latest craze of adult colouring in books. So that is going to be one of my something new.
Keeping physically active is also a key to managing pain. But fear often hinders this.
Fear will affect people's perception of whether they can move well. It will affect the rhythm of their movement. It will reduce their activities because they think things that they do are going to make it worse. But as we start to be more stagnant, we are building ourselves to be more deconditioned, and there's more chance that we will continue to have a pain syndrome.
So overcoming fear and maintaining as much mobility as possible is crucial.
That's when getting the right physiotherapy or exercise therapy or the right strength and conditioning is the correct way forward for the patient.
Squeeze the heels into the floor.
To help increase the patient's self-belief that they'll recover, this clinic uses the same professional equipment used by athletes.
A sense of hope is sometimes the thing that we need to build back in again so that they can follow a treatment path.
Greg's now had his permanent implant for 2 weeks, and he's travelling well.
I can move, I can walk. I can now walk 3 blocks, yay me.
As the trial has only just begun, it's too early to say if the implant will work for everyone. But for Greg, the reduction in pain has been significant.
Prior to the operation, I was up around 8 out of 10. Now it's around 2s. So it's been a massive reduction in pain. Now I'm off all the painkillers. So I'm off Endone, I'm off Valium, I'm off Targin, I'm off Dovdep, I'm off Lyrica, I'm off Panadines. When you take all of those out of your body, all of a sudden things become clear again. So I think the biggest change, apart from not being in constant pain, is this clarity of thought again, where you're starting to feel things around you and see what's going on.
Once again, he's been able to enjoy time with his family.
I can actually pick up the grandkids and spend time with them, and I don't have to go and sit and they don't have to be quiet around me. It's given me back to the family, and family dinners have been fun. It's been good to be part of it again.
It's good just to see him back, enjoying life again and, out of that pain haze. He's back to the old Greg that we knew. He's laughing, he's jovial, he's back to his normal, funny self with the kids and cracking funnies. He's back to the man that I married 31 years ago. It's the boy that I fell in love with. So I've got him back, and that's good.
But now I feel as though, there is a future out there, and I'm only young and I've got the family, and I'm very positive about the future, excited about the future, excited about where it'll lead, and hopefully some way pay back in some small way what people have given me. So, very happy. Guys, thanks.
Cheers.
Good health.
Cheers. It's good to have everyone together again.
Maddie.